Evaluación inicial de la espasticidad.
SMD Decision Tree. Speaker, Dr. Jörg Wissel, specialist in neurorehabilitation, movement disorders, and botulinum toxin treatment.
Vamos a presentar entonces al doctor Jörg Wissel, quien es doctor en medicina, miembro del Real Colegio de Médicos, certificado en neurología. Es especialista en neurorehabilitación, movimientos anormales y tratamiento con toxina botulínica. Es autor de más de 150 artículos científicos originales en el mismo campo. Desde el 2001 al 2024 tuvo a su cargo 2 unidades de neurorehabilitación en Alemania, la Belitz Helstenten y el Departamento de Neurorehabilitación y Terapias Físicas del Hospital Vivantes Spandau en Berlín, desde el 2013 al 2024, la cual es una clínica especializada en neurorehabilitación. Desde el 2002 ha tratado 250 pacientes al año con toxina botulínica en su clínica privada en el centro de Berlín, en Alemania. El profesor Wissel es profesor de neurología y miembro de la facultad de la Universidad de Innsbruck en Austria, así como también es profesor de la Universidad de Potsdam en el campo de salud Brandenburg en Alemania. En el año 2024 recibió el Premio Alemán de Rehabilitación de la Sociedad de Neurología y Rehabilitación. Desde el 2024 también es cofundador de la compañía AE in Healthcare en Austria. Es científico tutor asesor de la Sociedad Alemana de Distonía y chair del grupo de estudio de espasticidad de la MDS. So, for me, it's an honor to introduce you, my mentor, my professor, and my dear friend, Dr. Professor
Thank you,
Wissel.
Macarena, for this nice words. I really enjoy to stay in contact with you, and we always have good ideas to cooperate and talk about new projects. So of course, I'm thankful to bring this information from today to Chile and hope that we have a fruitful discussion afterwards. So the topic of today is the decision tree tool, which is for detection of problematic spasticity. And we validated this instrument for nurses and therapists, and I show you the data, and I can give you the information that it's under publication in terms of we send it to the magazine Stroke, and it's under review now. So my disclosures, and you already mentioned my disclosures. So I start with the background in Germany, and maybe you can compare your pathway in South America countries with respect to the typical post-stroke care pathway. Though in Germany, after initial acute care or rehabilitation, the discharge is typically to primary care healthcare professionals, HCP healthcare professionals. And this is a general practitioner, occupational therapists, physiotherapists, or nurses for an ongoing management. Being in this management of the HCPs, there is a lack of specific instruments for GPs, nurses, and therapists to identify problematic spasticity. Even GPs and nurses don't know exactly what spasticity is and what complications can happen, and therefore the time to the diagnosis, and without diagnosis no management, and management of problematic spasticity varies a lot in Germany. Often, in many cases, it's identified when complications occur. And of course, that's too late. So we should identify earlier, but it happens in many patients that complications occur, and I will show you complications occur early. So we have to have an instrument to make the diagnosis and to refer to special treatment, to special management from PM&R physicians, neurologists, and specialized multi-professional team that can handle problematic spasticity. So clinical predictors, so to identify those patients early would be of profit, of course, for the patient, also for the caregivers that often also suffer from taking care of the patients with severe spasticity, and the healthcare system to have an ongoing management that is adequate for patients that are affected of spasticity. So how many patients are affected from spasticity itself? Actually, when you go to the literature, and this is the literature review of all this diagnosis, and then you find prevalence of spasticity, and usually it's classified as spasticity when there is a velocity-dependent increase in muscle tone, but this is not problematic spasticity. Problematic spasticity is spasticity that lead to disabling situation from spasticity, and therefore we should have the chance to predict disabling spasticity when it causes harm or pain. For this, I start a little bit with the background. So today, there is, let's say, consensus that spasticity is only an umbrella term, and we do need other nomenclatura, other words for it. So we have to revise our taxonomy. So therefore, in the Movement Disorder Society and in many other specialized cohorts, we nowadays speak about spastic movement disorder. And the spastic movement disorder consists of a muscle change in that syndrome, so a muscle disorder that happens from an upper motor neuron lesion, and spasticity. And of course, paresis. Spasticity here as an umbrella term, it is defined as the Lenz definition of velocity-dependent increase in muscle tone. But you all know there are many other features that also are disabling. For example, spastic dystonia, co-contraction of antagonists, extrasegmental co-contractions, synergias or dyssynergias, and nociceptive spasms. So there is agreement that one should certainly research preventive therapies in the early stage of a central nervous system lesion using techniques to prevent or minimize the emergence of spastic myopathy and its neuronal consequences, the spastic movement disorder, and contractures. So that's the background. So there is actually a lot of information, and this systematic review put together information from a lot of published prospective cohort studies, and it came out that the incidence after first ever stroke of spasticity is very high when the stroke patient shows a paresis, and the risk factor to develop a disabling or severe spasticity is high when it is a moderate or severe paresis that lead to disabling spasticity or reduction in activities of daily living, when the motor phenomenon is combined with the sensory disorder or a hemorrhagic stroke, or when it is a big stroke. so a large volume. So I was reviewer of this publication in that magazine, and though I am able to present also the data in a summarized way. So they looked to 23 studies and they provide the data, and what they show is that spasticity, velocity-dependent increase in muscle tone, is not a very good predictor, because you can have spasticity, this type, velocity-dependent increase in muscle tone, for example, in the quadriceps muscle, and that may help you to stand upright after stroke. But problematic, severe, disabling spasticity, actually the numbers start very early too, but lower frequency, lower number of patients, but they rise up to 3 months and then are relatively stable in that way that it is about 18% that are affected from problematic or severe spasticity. So pathophysiologically wise, we have this neuronal phenomenon, which is velocity-dependent increase in muscle tone, spastic dystonia, synergias, and we have the changes in the muscle properties. And looking to what happens when spasticity develops, we see that beside the neurological phenomenon, complications occur. So spastic fists, deviations of the forearm, of the arm in a typical manner, as well in the lower limb, spastic equinus or pes equinovarus. So this complication with fixed contractures are really problematic, and they show a maladaptation or maybe a malplasticity when not treated or managed. Another phenomenon that is important to understand why we developed this decision tree for problematic spasticity is the phenomenon pain. So how often stroke patients develop pain? So I can show you data from a study which I had the privilege to do. And we looked at 272 patients with chronic spasticity. So after 3 months, after 6 months, and what we found, pain was very frequent. And when you look to the upper graph, you see that actually only 26% had no pain, but 74% had pain. So a lot of patients had pain, and there was also a kind of correlation to the severity of spasticity. So the more severe the pain, the more higher the modified Ashworth score as one measure of the spasticity severity, quantification in spasticity. So putting things together, the information today, there is a significant time lag, I can say, for Germany, but for Europe, US, and I think it's also true maybe for South America, that after acute stroke care or stroke unit management, the time lag to start with the management of spastic movement disorder, SMD. In Germany, about every 5th patient, every 4th or 5th patient after 4 weeks post-stroke showed spastic movement disorder. And we just learn, and we know from epidemiological study, prospective cohort study, that the complications also start 4 to 6 weeks after this first ever stroke event. And therefore, we have to start treatment to avoid complications, to avoid this collagen hyaluronic acid deposits in the muscles. We should have a management of the pain levels patients develop. And of course, we should do early treatment to avoid shrinking of muscles and soft tissue structures and avoid joint contractures. Beside the first cohort, we did another study and published in 2020 in this journal, and we looked at typical stroke scales that are used in a stroke unit management following stroke. And we looked to the modified ranking, the NIHSS stroke scale that is usually used in stroke business, and a scale that judged about the mental capacity, though the mini-mental state examination very frequently used in this context. And what we found when we evaluate the patients very early in a cohort of 145 first ever stroke patients, in 35 patients, so about 24%, we found that with these three scales, we could predict disabling spasticity when we are using certain levels of that scale. So when the modified ranking is greater than 2, or the NIHSS is greater than 2, which is not a difficult situation following a stroke, and the mini-mental state is below 27, then patient developed severe spasticity in the joints that are here shown in the graph on the lower left side. And we could predict this very early with a high sensitivity of 94 and specificity of 93%. So also stroke scales in typical stroke units used can predict spasticity. So what is with the imaging data? So in modern stroke unit management, every patient has a CT scan or an MRI scan. So we look to the MRI scans and we try to find correlation between the lesion and the development of disabling spasticity. So what we found, when the lesion is large, and that explains it's not only the pyramidal tract, it's also a lesion of the parapyramidal tract. It's a lesion of other associated connections in the brain. That explains us why also psychological or neuropsychological deficits in the mini-mental state are correlated with spasticity. When the lesion is bigger, the chance to develop a spasticity is higher. And even when the lesion is situated in the MCA subcortical pyramidal tract capsula interna region, though the volume and the location counts. So when you like to judge whether this patient you just have on your ward has a predictor for severe spasticity, you also can look to the imaging you have. And when you found a subcortical lesion located in the capsula internica subcortical in the MCA area, and it's a large lesion, and the patient has a sensory deficit, a moderate paresis, which is disabling a low quality of life, then you have all the predictors that are now actually published that can predict a chronic situation where patient develops a disabling spasticity. So putting all this information together and focusing on clinical predictors, because not every patient has an MRI scan or an actual CT scan available. The question is how to identify patients on risk for problematic spasticity before developing contractures and fixed postures. And there are a lot of instruments available actually to check how is the level. There are patient questionnaires, but one questionnaire actually that is supported from the World Stroke Organization, the PSC, the post-stroke checklist, has only 2 questions to identify to handle spasticity. There is a very large questionnaire, complicated, a lot of questions, very time consuming. So not very, so we thought this is not enough to have. Then there is a screening tool for contractions. That's too late. And there is the post-stroke referral tool, which is also a very good tool to identify, but includes images, and imaging, as said before, not always available. So we focused in our development on the SMD decision tree on clinical markers, and we used validated and reliable scales with good numbers in this evaluation. We used the modified Ashworth score, the motor control impairment, the MRC, the Medical Research Council scale, and we use modification of the spasticity-associated arm pain scale. And we, of course, made that scales easier to be, it could be handled by nurses and therapists. And we simplified the scales so that severe impairment and moderate impairment could be identified by the person that is doing the screening tool. So I give you an example from the modified Ashworth scale. So you know the modified Ashworth scale is a 5-level scale, but knowing about the predictors, we know that if a patient develop more marked increase in tone in a joint, or a catch and a moderate increase in muscle tone when passively stretched, there is the risk. And therefore, we can simplify this 5-level scales to actually 3 levels, where we have the information that if there is a mild tone increase with mild resistant a catch during half of the stretching of a joint, or when there is more than that, so the whole range, or there is a very severe resistance against passive stretch, those are the levels where the patient is on risk to develop disabling spasticity. So what is with motor control? When you have a spastic tone in the biceps, it is important to stretch that biceps to treat it. And therefore, for the motor control level, it is important to know how the antagonistic muscle is impaired. So the motor control in the antagonistic, the example was the biceps, so the control in the triceps is important. And here it is important whether the patient has more than 3 on the Medical Research Council scale in the triceps. So able to activate the triceps and can stretch the elbow against resistance of spasticity. That is no significant impairment. But when this is not the case, 3 or greater or lower than 3, then there is a high risk of development of a spastic contracture. Therefore, the next level, the next scale we include is the spasticity associated arm pain scale. It looks very complicated here, but in the end, it's easy. We included in the decision tree the evaluation of the elbow, the wrist, and the fingers, and we judge about whether there is a pain when we stretch the joints, elbow, wrist, and fingers, long fingers, or not. If there is no pain, then the patient will do it by herself or himself. But if there is pain, then the patient will not stretch and will have a higher risk to develop contractures. So this is the case when the SAPS has a level of 1, pain during repeated movements, or higher than 1, 2, 3, 4, then there is a high risk. So this is a whole decision tree, and you recognize it's a sequential evaluation of the muscle tone with the modified Ashworth scale. After that, you do the motor control impairment in the antagonist of the muscle that you looked at, and then you do the pain evaluation and you move the joint 3-5 times, and then you judge about the pain. Of course, you should start with the joint, elbow, wrist, or fingers, where you have the impression that the spastic tone could be the worst. So then it would be easy. So maybe we start with the elbow, testing the elbow. You have a 1+, this is resistance half of the range of motion. And then you do the next level, testing the triceps. And in that case, you have a patient where the stretch without resistance, with the, triceps is possible, but with resistance, not possible. Then you test 5 times elbow movement, and then you have pain during multiple movements that would lead to the recommendation this patient is on risk to develop a problematic spasticity. So I have a video and I show you when I evaluate. I know that you don't hear the tone, but of course we have the English translation here. So I said to the patient, I do the first step of the evaluation in the elbow. So I stretch and I move. So then I ask her, did it hurt? No, it doesn't hurt. The movement was possible, but she could stretch the whole range, and no pain, so there is no risk here. It doesn't hurt. Okay, so elbow is easy. Then you document, and actually nowadays electronic documentation is available. You recognize the scale you already saw, and for the elbow, everything easy, no risk for spasticity. So what is with the wrist? So can move, but you see there is a catch. So it's a 1. And you remember a 1 is a risk. So now are the extensors able to stretch now against resistance? That's possible, but not against forceful. Though there is a risk, but no pain. Okay, so there is a minimal risk. The same is true for the fingers, and therefore with this no risk, so with this catch here, it goes to this level with no pain following this recommendation, you will end in a recommendation to show the patient to a specialist because there was a velocity-dependent increase in the flexors. So it's possible with the scale to detect spasticity. Of course, we now did an evaluation of the scale with a cohort of 70 stroke survivors, and we had as a gold standard the evaluation of 2 specialists, and the validation was done by the decision tree by an inter-rater reliability by comparing referral decisions made by non-specialized nurses and therapists with the gold standard, a patient assessment by 2 experienced physicians. So referral is when there is an indication of management or when the referral tool leads to no referral to a specialist. So we included more than 60 patients in that study. It is a prospective cross-sectional monocentric validation. It was done in an Austrian rehabilitation clinic, and we had a 4-week screening phase and then 4 examinations per day. So there was rater group 1 nurses, rater groups 2 therapists, and 2 specialists. And on each examination day, each rater group consists of 2 raters. So rater group 1 and 2 nurses and therapists, and rater group 3, 2 physicians. So there was a randomized order in terms of who examined the post-stroke patients first, but in the end, every cohort examined all patients. In between the examinations, there was a 30-minute break, and the patients was blinded for the raters, so they didn't know whether it was a nurse, a therapist, or a specialist. So the patient was blinded, and you see every patient had the chance to be rated by a physician, a therapist, and a nurse. So we estimated these levels, and therefore we calculated should be more than 66 patients. We did the adequate analysis, and we can discuss later if you have questions. So these were the study participants, 69 patients, 5 nurses, 4 therapists, and 2 experts. So these are the baseline data of the patients that were examined, though a typical cohort in the acute, subacute phase following stroke. And what we found, so the physicians were the specialists. There was a very high level of agreement between the nurses and the physicians when using this sequential way of the decision tree, looking at first to muscle tone, then to the power of the antagonist, and then to pain. So 85.5% was the agreement, and the Cohen's kappa as a statistical measure show a substantial agreement, and it was even better, the agreement and the Cohen's kappa when comparing therapists with physicians. So the rater feedback was there are strengths. It's easy to use the SMD decision tree. Of course, there are challenges, and the therapists also made it easy, straightforward, and streamlined patient assessment very well. So the conclusion, nurses and therapists demonstrate substantial agreement with evaluations performed by experienced physicians that could identify spasticity that does need treatment. And there was a high sensitivity and a high specificity when using the SMD decision tree. So the study showed that and was empowered, though that it could be shown that the scale, the decision tree empowered nurses and therapists to screen effectively post-stroke spasticity, to identify patients that does need a management of the velocity-dependent increase in muscle tone of the spastic dystonia. So to summarize the results, there is a risk of disabling chronic spasticity, and that leads to muscle shortening and contractures and pain. Using clinical predictors in the SMD's decision tree allows to identify patient that does need treatment of spastic movement disorder. There is the toolbox. There is the treatment of contractures. So that is what is available when it's too late, when it's not identified early. When it's identified early, we have all that measures that can treat spasticity. So the decision tree enables to identify those patients that does need specific management. And therefore, the statement, the earlier post-stroke spasticity is recognized, for example, by using the SMD's decision tree. The post-stroke spasticity can be managed with physical treatment or even with botulinum toxin treatment. So this is the team that did the iRefer study. And thank you very much for your attention. And I'm happy to answer your questions now in the following discussion time. Thank you very much. I close the presentation.
Oh, thank you very much for your lecture, Dr. Wissel. In Chile, it will be very useful to help.
Okay. I don't hear you,
guide.
Macarena.
Okay.
I don't know why.
You? And now? And now? Can you hear me? No? ¿Los demás me escuchan? Por si acaso.
Now I hear you. Okay.
Perfect. Thank you very much for your lecture. In Chile, it will be very useful to help to guide or conduct as a medical team. So it will be very useful to unify criteria. So, ¿la audiencia tiene alguna pregunta para el Dr. Wissel para que se pueda discutir? ¿Hay alguna pregunta? No? There's no question for you, Dr. Wissel. So finally, do you have any take-home messages to our audience?
Yeah, of course, the take-home message is that we should recognize patients on risk for developing severe spasticity, but because when spasticity is actually developed and becomes severe, there is the high risk of contractures, and the 3 levels of evaluation here are the muscle tone identification, the identification of the strengths of the antagonist, and whether there is pain when passively moved the limb, because when there is pain, the patient don't move the limb. But of course, it's necessary to put the limb in a good position to avoid contractures and to enable the recovery, to have muscles and joints in a proper condition to re-emerge motor capacity, to maybe relearn movement, active movement. But this is only possible when spasticity doesn't hinder. So that's my actually essence. So start early in identifying, and when you identify, you should manage properly.
So on behalf of our President, Arlette Duselin, we would like to thank you once again for your participation and extend an invitation to visit Chile in the future.
Yeah, thank you. I really would like to visit you and to discuss with you these topics in your hospitals, in your settings, to hopefully find ways that you can apply to manage your patient properly. So thank you very much for inviting me, Macarena. Thank you very much to the society that enabled us to have this presentation and discussion. And I wish you a very nice day in Chile. So greetings from late afternoon from Germany.
Bye. So, finalmente, queríamos agradecer a todos los participantes de esta lectura, como Red Neuro Araucanía, por la participación, y los invitamos a inscribirse y ser parte de nuestra red, y que tengan un muy lindo jueves.